I'd like to welcome Dr. Jorge Aloa, a vascular surgeon from Colombia. He's the chief of vascular surgery at Santa Fe Foundation, a professor of vascular surgery at Universidad de los Andes in Colombia, and the director for the American Venous Forum. Besides being an excellent mentor and role model for his trainees, he's been a leader in developing new technologies. So, Jorge, what is this new venovalve that you've been working on?
Anil, this thing it's going to be and seems to be an extra step in the long research that has been done in order to try to fix the problem of the deep venous system reflux. We are stepping in 60 years plus of research, trial and errors, and very, very interesting research that has been done prior to our development. This thing seems to be, or it is, the longest report so far with 36 months, with very encouraging results. And we are very confident that this is going to be the last of a chain of evolution that will solve the problem once and for all.
So how did this get started, and where are you now with this new technology?
It was a conception that was done in Irvine in California by Mark Glickman and his team. We have been adding some extra steps on the research from the bench side, then the animal. And finally, we got into for the first in human in Colombia. We did and performed some number of patients, and most of them did very well. Some of them didn't, and we were on the learning curve. And then after those results, and we proved that it was feasible and it was something that we could achieve, we move and migrate into the pivotal study that has been done and already been closed in the United States. 75 cases has been performed in 30 centers, and the data is still being collected and being analyzed and will soon be presented. I'm assuming that it's going to be in a couple months at the VITH Symposium, New York.
So which patients are possible candidates for this technology?
Most of them are deep venous system thrombosis that has been under a complex resolution of their problem that ends up in the destruction of the valves. So basically, it's post-thrombotic syndrome. We barely have primary venous incompetence, but of course, in the second stage, we included some of those cases. Most of the patients are going to be post-thrombotic that has been exhausting all the processes and all the efforts that the medical and the technology can offer them. After a while, if the patient continues with a deterioration in the quality of life, and high levels of Villalta scale, and really doing poor in a day-by-day basis, they can explore the opportunity or the option of having an implantation of this device that will, for sure, make a change in the quality of life.
Are most of these patients C6 patients or C5 patients?
The first in human included all of them were C6 and C5s. Now the pivotal moved one step below, which is C4Bs. And I think that's going to be from C4 when you begin noticing skin changes in a post-thrombotic syndrome. But not only that, when the patient is doing poorly, a lot of pain, a lot of edema, impairment of doing his or her day-by-day activities, regardless if it is a C5 or a C6. Of course, C6 do better than the others because we are achieving healing of the ulcer in a very fast rate. But all the other C5s and C4s get the benefit also of this thing.
I know you can't present all of the data that's been going on, but you presented some of the data before. What have the results been so far with these trials that you've been using?
I'm not sure about the numbers that the pivotal study will show. We are still, as I was telling you, analyzing that, but it seems that they will echo whatever we did in Colombia. So we have about a 10 to 15% rate of failure in our analysis in our first in human. And it seems to be that it's going to be something close to that in the pivotal study in the United States, which is still, we have an 85 plus rate of success, which is something not very bad at all. And the statistics and the data so far with this device is the best that has been shown in the history of trial and errors of different types of reconstructions, and either heterologous, autologous, autotransplantations using the same tissue of the patient, or in this case, this prosthetic device.
What's the next step in the development of this technology? It sounds really exciting, especially in a patient population that's been largely not had many good options. And as you said, we've tried all sorts of things and have lots of failures. So this is a badly needed device and may actually help a lot of patients with their quality of life. But where do we go from here? What's the next step?
The natural evolution of this device is going to be change the stainless steel that has been using it for the last 3 to 4 years in a surgical open fashion, and add nitinol on that and wrap it up into a catheter. Probably it's going to be a 13 French catheter, and then the deployment is going to be endovascular. We're still working on the idea of how many devices will be done, will be necessary, and many other technicalities and technical aspects that needs to be work out on the process. But I think that in less than a year and a half, we're going to have surprising news about endovascular accesses of this thing. That's going to be the natural and the logical evolution step.
Jorge, thank you for sharing this experience with this groundbreaking technology. I think it has the potential to really be a game changer and really help a lot of our patients that we see commonly with very advanced venous disease.
Thank you, Anil. We're very, very confident that it will work, but of course, we're very cautious also about the analysis of the data that has been arriving and will be arriving in the near future. I'm really trusting that this thing will make a change, because I've been implanted it and I've been seeing the faces of my patients and the improvement in their quality of life. But I'm very, very confident that it's going to be surprising and positive news. Thank you, Neil, for the kind invitation.